All right, so good afternoon, everyone. I would like to welcome you to this webinar, Understanding Clinical-Related Critical Incident Stress Experienced by Undergraduate Nursing Students, a guide for clinical nurse educators. My name is Keith Barrio, and I'm the Senior Officer here at Kazan. Before we jump into this, I would like to today's presentation, I'd like to give a moment to pay respect to the lands in which we are situated. The Canadian Association of Schools of Nursing respectfully acknowledges that its national office is located on the traditional unceded territory of the Algonquin people. Kazan would like to acknowledge and pay respect to the Algonquin people who are the traditional guardians of this land. We acknowledge their long-standing relationship with this territory, which remains unceded. We pay respect to all Indigenous people in this region from all nations across Canada who call Ottawa home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. Now, with today's webinar, we will begin with a presentation, and then we'll also conclude with time for questions at the end. To submit a question, please use the Q&A button at the bottom of your Zoom window. We encourage you to use the chat function to discuss and share with your fellow participants. However, the chat will not be monitored throughout the presentation. Another notice as well is that this presentation is being recorded and will be posted on Kazan's YouTube channel for future viewing. Following the presentation, we will also make the slides available and also provide a link to a post-webinar evaluation survey at the end. And with that, I am pleased and honored to have with us Doctors Juliana Harvey and Jamie Gallagher. Thank you very much to all our speakers for coming together for today's presentation. And with that, I will turn things over to them.
Great, thank you so much, Keith. Welcome, everyone. We're excited to have you here today. My name is Jamie Gallagher. I'm currently a manager of clinical education, interior health, located in Kamloops, BC. I have been a nurse for almost 20 years, and about 16 of those years I was teaching or in an educator role. And so the presentation that we're going to be talking about today and some of the resources and the paper that Juliana and I co-authored is something that I wished I could have had when I was teaching students in the clinical in the hospital, because I had a few incidences where a bit of a framework and a resource to lean into these supportive conversations would have been really helpful. So I really hope you get something out of it today, and I hope we give you some tools and some different strategies to use in your own practice and to share with others. I'll hand it over to Juliana.
Everyone, welcome. My name is Juliana Harvey. I'm an associate professor in the School of Nursing and Midwifery at Mount Royal University, and have been involved in education since 2009, at least at Mount Royal, and am privileged to teach across the program, including the clinical setting. And so this topic, again, resonates with me, having worked with students in experiential learning environments where it's labile, unpredictable, and sometimes distressing for students. So the objectives for the next 90 minutes or so is to offer you some information, literature, research, the topic area, understanding clinical-related critical incident stress, is a program of research for myself and some colleagues. And so the work that I shared today around that scholarly piece is my work, but it's also my work and my colleagues' work, but it's also other scholars in the field. So we've drawn on what exists on the topic to offer you an overview. And then to look at some strategies, potential strategies that might offer educators in the clinical area support and assistance so that they can work with students using a trauma-informed approach. And then finally, to apply a framework, the Promoting Excellence and Reflective Learning in Simulation, or the PEARLS framework, a simulation framework that exists, but underpinned with a trauma-informed approach to guide conversations with students who experience or may experience clinical-related critical incidents.
Yeah, so as Juliana outlined, for the next 60 to 90 minutes, Juliana is going to dive into some of the theoretical content relating to her research. And as she was just saying, she's well-versed and well-experienced in this area and is published widely. So I'm really excited for her to share her findings, as well as we are going to be posing a bit of some practice questions, and a clinical case scenario that we really hope can have you apply the resource and the cognitive aid, the tool that we designed using the Pearls framework. So there will be an opportunity to promote some reflective practice within yourselves if you have the capacity to stay up until the very end. That being said, we aren't able to have large group discussion with mics or cameras, but we really hope that you're still able to engage with us through that reflective learning activity towards the end once we're done reviewing the theory. So the talk might take us up through the full 90 minutes for those who are able to stay. And as Juliana just reviewed, these are some of our objectives to go over. So she went into detail around these. So with that, I will hand it over and we will dive into some of the background.
Scholars agree that learning in the clinical environment is perceived by undergraduate nursing students as stressful. And I'm talking about here the day-to-day wear and tear occupational stressors. Stress has been described by authors in the field coming from personal, so potentially an example might be financial struggles, academic, or that clinical context. The common day-to-day clinical stressors perceived by students as stressful typically revolve around patient assignments and workload, relationship dynamic or dynamics with instructors and staff nurses, and a perceived lack of professional knowledge and skills, so more specifically knowledge gaps that they might experience. Unlike the day-to-day occupational stressors that I just briefly alluded to, students may experience what's called a critical incident. And a critical incident is different than the day-to-day wear and tear or occupational stressors because it's sudden, it's unexpected, it can be perceived as traumatic, and it has the potential to compromise typically used coping strategies, and it may result in distress. The nuance of a critical incident is that it can be subjective, it can be individualized. So what one person perceives as a critical incident might not be perceived as a critical incident to another. Those who experience critical incidents might experience responses. And so it may be physiological, psychological, spiritual responses. And those responses are referred to as critical incident stress. And I'll talk a little bit about those in a few minutes. I just want to briefly highlight why the topic. Why is this significant? And there are a variety of personal and professional implications that reinforce the significance of this topic. I'm going to highlight three. So first, work-related critical incidents in graduate nurses, or those who are currently in practice, has been correlated with both negative and positive implications like post-traumatic stress disorder and post-traumatic growth or benefits. Second, critical incidents in undergraduate students may have physiological implications, for example, sleeplessness, hypertension, headaches, nausea, psychological responses, so feeling inadequate, difficulty concentrating, altered self-confidence, self-esteem, just to name a few. And then third, critical incident stress has the potential or may impact the progression in the future of nursing. And in some of the work that we've done, participants in our research have highlighted that they've questioned, after critical incidents, they've questioned their undergraduate education, the pursuit of nursing as a future career. So to better understand the topic of clinical related critical incident stress, I want to offer a few examples, descriptions from participants in our studies who have described their experience of critical incident stress. Note that the examples and the descriptions that I share are available in the manuscripts that have been published. So if you're interested, you can go and explore those in further detail. I'm just going to give you a little overview of the ones we've identified. So the examples were varied. No two or three examples were alike. And so the more commonly described critical incidents by learners were around experiencing a sense of uncertainty, vulnerability that was underpinned by a lack of support and the power imbalances with clinical educators and staff nurses. And so again, I'll just share an example that was highlighted by one of our participants who said that they withheld their patient's antihypertensive medication because of a low blood pressure. The medication was later administered by the responsible nurse, the staff nurse. The patient experienced a serious hypotensive crisis. The nurse blamed the student for administering the medication, and the clinical instructor responded to the situation by minimizing the incident. And so the instructor's lack of support unknowingly contributed to the traumatic nature of the incident. Many of the critical incidents described were influenced by moral distress from ethical dilemmas that students had experienced. And so again, another example, a participant described being forced to administer a medication by the staff nurse to a patient who refused. And the act of administering that medication to a patient who didn't want it elicited moral distress, and that resonated for that particular student. Several learners shared critical incidents that related to empathizing with patients who had suddenly or unexpectedly deteriorated. And so feelings of guilt and uncertainty that emerged as students questioned if they had made the mistake or missed an intervention, maybe had missed an assessment that led to the patient's deterioration, was quite significant and impactful. Jamie, if you could just switch the slide to the next one, please. And then nursing students have talked about, or had talked about in our research, this mismatch that occurred between what they had been taught in the classroom and what they had witnessed in the clinical setting. And that contributed to some experiences that were perceived as significant and traumatic. The ideals, more specifically, that they were concerned about or that were impactful were the concepts of compassion and advocacy, those theoretical pieces that they had heard about in the classroom, but they weren't observing in the clinical setting. So one participant used this phrase that really resonated with me, and they said, "I was so disillusioned by the practice." And then they went on to describe the experience or the moral distress that they experienced when the staff nurse lacked time to attend to a patient's pain control level. And it shattered their ideals about what they had been taught around compassion and, as I've said, advocacy. And it altered their perception of the nursing's professional identity, but also the role of the nurse. Undergraduate students, as I've said, experience clinical related critical incidents, but they also experience the responses, so that critical incident stress component. And so what we've highlighted, or what we've identified in some of the studies that we've done, is experiences relative to critical incident stress. And those experiences were around altering the student-teacher connection, creating a sense of uncertainty. Participants had highlighted that there were benefits that they experienced, that critical incident stress tainted or impacted the optic of perfection, and it disrupted their perception of nursing. And so I want to just talk a little bit about each of those components before we go on to strategies and interventions. So critical incident stress may lead to fragmented relationships between the student and the clinical educator. Participants in our work alluded to their fear of showing vulnerability and emotion because they were concerned. They saw it as high risk. They were concerned about being perceived as weak, incompetent. They were concerned about being placed on a learning contract, receiving poor evaluations and grades, and potentially failing the course. So they concealed their emotions. Critical incident stress may induce a sense of uncertainty, which students talked about altering their self-confidence and compromise their ability to fully focus in the clinical setting. Some participants in our research did allude to benefits that they derived, and they used this language of processing or making meaning of critical incidents, and that their experience actually helped them develop insights for future clinical experiences in the program, but also future experiences that they anticipated as a registered nurse. critical incident stress could lead to self-evaluation of performance. And students highlighted this transition or the illusion of moving from perfection to being flawed. And so some of the language that participants in our work used around this sense of perfection was feeling imperfect, feeling weak, inferior, and powerless. And so there was this intense need for some participants to maintain this optic of perfection. And when they experienced their critical incident, it compromised their ability to sustain this unrealistic standard of being the need to being perfect. And then this type of stress facilitated a disintegration of assumptions that students had constructed about the role of a registered nurse and the work of registered nurses. So for some participants, the ideals that were taught in the classroom or by educators became questionable, it became unfamiliar, and it created this sense of confusion and distress. Understanding coping strategies or supportive strategies used by learners after critical incidents might be helpful for educators who strive to support students and learners' well-being. Last year, my colleagues and I published a research study. It was a grounded theory study that actually emerged from the language that participants had used in prior work, where they had said that they processed and they attempted to make meaning of these experiences. And so my colleagues and I became curious. What does that process look like? What does that attempt to make meaning look like? And so we conducted this work, this grounded theory that we titled Pushing Through, to describe these processes. Specifically, wanted to know, how do we understand the processes that students use to attempt to make meaning and cope? So pushing through is characterized by three distinct categories: distress, identity shift, and moving forward. In the distress, the circle around distress essentially represents the impact of the incident, and it's influenced by 6 conceptual properties. So the year of the program, the more novice or earlier in the program, the more vulnerable they were relative to distress or responses. Uncertainty, cognitive dissonance, feeling unsafe, so an unsafe space or setting, feeling unsupported, and this sense of guilt. All participants in this work, their descriptions of critical incidents exposed some degree of psychological and physiological distress, which compromised their ability to make meaning of that experience or incident. Identity shift took place as learners started to work through their experience or experiences, and it was affected by 2 components. So it was affected by the reset time and coping behaviors. And reset time was the need or the time that was needed to process their critical event and then resume clinical responsibilities. The time ranged, so they ranged from a few days to it was still ongoing. So it was just, it was hard for them to provide a definitive time. Identity shift also was dependent on the coping strategies that learners used, and there was diverse coping strategies that were described. Participants' coping strategies were personalized, and they included, I've listed some of them there, so repressing of emotions. They concealed, they hid their emotions. Avoidance, optimism. They used rationalization or problem solving to try to figure out the nuances of their experience. Self-care strategies. They highlighted seeking support, setting limits and boundaries, and then engaging in reflection, which looked different for all students. It is important to note that many of the participants used one or more in combination of these coping strategies. The outcome was moving forward. And several participants talked about moving forward involving strategy. So they strategically revisited their incident to support their current and future clinical practice. They saw the critical incident they experienced as a resource, as an opportunity to make changes in their future practices. Participants' description suggested that making meaning of critical incidents was an ongoing endeavor and that it remained unresolved. There are a variety of strategies that may be used, supportive strategies for learners who experience clinical related critical incidents. I would say this work is in its infancy, and so I'm highlighting a few, again, some from the work that we've done, but also some from other scholars. So this is I guess a variety of themes that have emerged thus far. So the significance of exploring preferred coping mechanisms. So as I've pointed out in the slide prior, there isn't just one preferred method. There's a variety. And so inviting students to vent, to reflect on their experience, to expand their self-understanding, but also to navigate their preferred coping mechanism. Many times learners don't know how they cope. And so giving them the opportunity to explore what might work for them is important. Acknowledging, validating, and normalizing learners' emotions or responses during these delicate and private conversations can contribute to a supportive rather than an evaluative tone. Nurturing those relationships with learners, the professional relationship between educator and student. The student-teacher relationship underpinned by trust and mutual respect has been correlated with positive influences on students' clinical learning experiences, and in particular, their ability to synthesize knowledge. And so really nurturing that relationship is significant. The significance of community. Learners who experience a critical incident in a variety of the work projects that we've done have highlighted that they value the significance of community, and that community is their clinical group. It's their peers who are at the same educational level and place the same value on learning. Our work has highlighted that distressed students want immediate support, and they prefer that support from their peers because they're there. They've talked about texting them if they're on a different unit or in a different room, contacting them through messaging. So using social media, or not social media, using text messaging or technology to try to get the attention of their peers to offer them support was important. And the benefit of connecting with their peers in that timely manner was that their peers already had context. They were typically already aware of the situation because they were either in their clinical group or they had the student had shared it with their peers. They already knew, so they didn't have to worry about the additional burden of elaborating on the context. And then finally, considering the integration of a trauma-informed approach into nursing education, but with emphasis on the clinical learning environment. And I'm going to talk about that here in the next few slides. So the risk of exposure to clinical-related critical incidents perceived as traumatic, and then the potential for re-traumatization from past personal experiences adds complexities and complexity for the student as well as the clinical educator. And so a trauma-informed educational approach might be one way to navigate these challenges because it requires educators to be aware, to be sensitive, to be responsive to all students, regardless of whether they've experienced a critical incident. According to the Substance Abuse and Mental Health Services Administration, a trauma-informed approach is grounded in 4 assumptions, or the 4 R's. And that includes realizing the impact of trauma, recognizing the signs of trauma, responding to applying the principles of a trauma-informed approach, and actively resisting re-traumatization. These assumptions are rooted in the application of 6 key principles of a trauma-informed approach. And those principles are on the opposite side of the slide there. So safety, both physical and psychological safety, trust and trustworthiness, peer support, collaboration and mutuality, so shared partnerships, empowerment, voice and choice, and then cultural, historical, and gender issues. So a trauma-informed philosophy should be considered in all components of the clinical learning experience, regardless of whether a critical incident has occurred. Before I highlight strategies relative to a trauma-informed approach, I just want to make sure that we're all consistent with language. And so I just thought I'd put these three terms on the screen so that, again, we're all in alignment with the language being used. So the typical structure for a clinical learning experience consists of a pre-conference. It may or may not consist of a midday conference and post-conference. So pre-conference is the small group or one-on-one discussions that might be had with learners and the educator, and it's typically implemented before students begin their clinical experience. And often it's used to ask questions, an opportunity for the educator to evaluate the student's readiness for patient care. The midday clinical conference typically takes place literally in the middle of the session, and it's used to get a sense of where the student's at, looking or evaluating the student's progress, and exploring potential needs to change priorities of patient care. And then there's the post-conference, typically done at the end of the clinical session, and it's an opportunity for learners to analyze their experience from that day, and for educators to create opportunities that allow for reflection, critical thinking, and clinical reasoning. So strategies for educators to integrate a trauma-informed approach should take place while preparing for the learning experience, during the learning experience, and then after that experience is done. And so I'm going to just offer some strategies using those three phases: preparing for, during, and after. Preparing for the learning experience, I think, begins with the development of physical and psychological safety. And really that should be thought about even before you meet the students. So in the emails that are sent prior to meeting the students, really being strategic and thoughtful in how those messages are being delivered. In terms of the physical safety, one of the defining attributes of an effective clinical learning environment is familiarity with the physical space. And so ensuring that that orientation is sound and solid. It includes opportunities for learners to explore the setting, to engage and manipulate the equipment that's on the unit, and interact with staff nurses. In terms of psychological safety, I'll just offer a brief definition. Amy Edmondson, who's well known for her work on psychological safety, she talks about the term as a perception that's related to the consequences of taking risks. And psychological safety is required so that students can participate and engage in learning freely without the need to feel to fear judgment or negative consequences. And so scholars have suggested that individuals and learners are more likely to feel psychologically safe when they engage, when they have trusting and supportive relationships with others. And so that really is, I think, the foundation to establishing psychological safety for learners in this context, developing a safe space from the moment that you meet the students. And this might and should involve getting to know students one-on-one, providing opportunities for introductions, and then options around whether and what they choose to share relative to their personal experiences and backgrounds. Getting to know students should include questioning the pronunciation of names and inviting learners, again, optional, to share their preferred gender pronouns. And these actions demonstrate to students an attentiveness to individuality, to diversity and inclusivity. Encouraging learners to explore their strengths and weaknesses relative to the learning objectives, inviting them to share potentially known stressors or past stressors that they experienced in the clinical environment is really helpful for educators to tailor their strategies. They're teaching strategies that promote well-being and hopefully prevent re-traumatization. Options and, sorry, don't keep going. You can go back, Jamie, to the other one, please. Options and autonomy. So as students disclose personal information about themselves, offering choice and autonomy is really important. And so in those introductions, offering options around how they share their information. Maybe they don't want to verbalize it. It might be in written format, and the audience with whom they choose to share that information with. Psychological safety is underpinned, as I've said, by positive relationships. This should be between students as well as with the educator. And so fostering this sense of community, this group cohesiveness with the group, could be significant for learners who really rely on peer support during distress. So to foster a community of learning, fortifying support among peers might be done through interactive activities, taking the time to get learners to become comfortable and familiar with their group and those that they engage and connect with throughout that term. Developing norms and expectations. So foundational to effective professional relationships with learners is the need for educators to demonstrate transparency for building and maintaining trust. And so this is initiated through upfront discussions with learners to allow for collaboration or the co-creation of group norms and expectations. And so being very transparent and upfront around elements like professionalism, what's expected of the student around professionalism, preparation for the clinical setting, methods for evaluating whether they're meeting their objectives or competencies, and even the strategies that you might use working with them in the clinical setting. So having learners involved in creating those expectations really solidifies a collaborative and a mutually respectful learning environment. I think another piece that I want to highlight relative to that, clarifying expectations should also delineate the nuances of the clinical educator role. And so being really clear about the distinctions between your evaluative and your supportive role. And sometimes they can become blurred when students experience these types of situations. And so reassuring learners that if they experience a situation that is distressing and they're showing emotion, that you're not evaluating them on showing their emotion, that you have your supportive hat on rather than the evaluative hat on. And I think making those transparent and upfront enhances this sense of transparency and hopefully offers or enhances trust as well. During the learning experience, teaching in the clinical environment involves flexibility, and it's certainly not rigid and linear. And so allowing for that flexibility, I think fosters an accommodation of students' diverse learning needs. And this requires educators to individualize their teaching methods to accommodate diversity. So ongoing engagement with learners is required so that you can explore preferred coping teaching strategies. And one way that might be done, and one strategy that is used, is thought-provoking questions to explore students' knowledge and help them engage in critical thinking and knowledge development. So effective questioning methods should reflect what one of my favorite scholars and authors, Jenny Rudolph, says, a stance of curiosity. And so this is about being open and understanding rather than being evaluative. So the intent of the question is used to explore learners' frames, perspectives, talk about what their thought process was behind their action or their decision making rather than penalizing for the decision that was made. So really being attentive to how questions are being used. Another component to think about during the clinical learning experience, or a significant component, is helping students in their implementation of psychomotor skills. They're excited, they're eager, but they're also nervous. There's anxiety and fear associated with potentially harming patients. And so just really giving thought to how teaching strategies are used in that context is important. So dedicating time for learners to discuss and mentally rehearse procedural skills before they go into the room, and their learning preferences. So how would you like me to best support you when I'm in that space? Do you want me to walk you through it? Do you want me to stay quiet? And that gives learners the opportunity for voice and choice. These discussions and feedback that's given to learners after their experience, being attentive to where that feedback's being given. So in a private space where questions and comments can be done in a comfortable tone for both parties. Prompt feedback is really important. So when the student is done with it, implementing their skill or task, that feedback is given to them in a timely manner, ideally immediately after the experience. And there is work that suggests that feedback from the educator is less effective if there's longer periods of time between the performance and providing them the feedback. Providing timely verbal and written feedback creates this sense of trust and transparency between the student and the educator. And then finally, just around this piece during the clinical learning environment or experience, students may be involved in patient safety incidents, which can be medical errors or near misses. And again, it's hard to tell which experience is going to be perceived as traumatic or distressing for learners. The more common patient safety incidents based on a research study I looked at in 2021 was related to medication administration and patient falls. Certainly there may be experiences outside of that, but that seemed to be the most commonly described experiences. And so a couple of pieces that the literature talks about to support students when those experiences happen: social support, particularly from staff nurses and student peers. That appeared to be effective in terms of coping. And that's the support that's given from the clinical educator. Learners prefer to have a discussion around what did they do wrong and what do they do to prevent that, rather than feeling penalized and judged. And then after the learning experiences or after clinical learning sessions, educators typically facilitate post-conferences, ideally in locations that allow for privacy and safety. And that's inviting learners to share their emotions, their reflections and highlights. If it's not in a private space, you're going to see them typically conceal those emotions because they're not going to feel comfortable. So participation, I do want to highlight, in post-conference might look different for each student. Some might be more vocal and others might not be as vocal, but are still engaged and participating. And so inviting learners to share anecdotes, emotions, insight, rather than forcing them, will align more effectively with the principle of empowerment, voice, and choice. And then maybe following up with those who might be less communicative. Maybe they don't want to share in that space, but they have something to say afterwards. Fundamental to the clinical educator role during post-conference is actively listening to learners, synthesizing key points, and supporting reflective practice. And so we might engage in techniques like discussion or analyzing certain situations. Debate might be another technique. These approaches will encourage learners to collectively engage in reflective practice so that they can gain insight into unknown or unconscious personal biases and assumptions that will then enhance their own personal growth. Not only should learners engage in self-reflective practice, but as should educators and those who facilitate instruction. And so educators' personal biases might influence their observation of students, their performance, and potentially impact the judgments and evaluations that might be made relative to competencies. And so clinical educators are encouraged to engage in self-reflection, to set aside biases, remain non-judgmental by role modeling to learners this stance of inquiry and inquisitiveness. And then finally, just a couple of key pieces around clinical related critical incidents. So what I've offered prior to this are strategies that can be used regardless of whether a student's experienced an incident. But I've just put this slide up because it is more specific to students who've experienced distressing events. Again, work in this area around strategies and interventions is sparse, it's lacking, it's in its infancy, but here are a few things that we've noted thus far. So those who experience distressing events, discussions, inviting learners to engage in discussions around what is a critical incident, what do we mean by coping strategies, and what are some potential resources should begin like the first day of clinical during that orientation, so that they're not surprised when an incident happens, because at some point it likely will in their career. So preparatory discussions should highlight some of the subjective nature of critical incidents and that personalized approach to coping, getting them to think about what might my strategy be before it actually happens and I have to use it. Is it problem-focused coping, or am I more of a logical, rational thinker that needs the problem-focused methods? Students might seek, I've talked about this throughout, peer support, and they seek that, at least from the descriptions that we've heard from our participants, as a way of concealing their emotions from their educator. They don't want to be perceived as weak and incompetent, so they're going to go to their peer. And concealing emotions, it makes it difficult for educators to notice that students need assistance and to respond. And so again, I'm just highlighting that piece around trusting professional relationships, because you'll get to, once you know your students, you'll get to know patterns and recognize that this is different for my student. This is not typical, and it might require that I ask a question around how are you doing? So delving a little bit deeper, and then offering timely support, again, preferably immediately after the incident. And then finally, acknowledging, validating, normalizing emotions might facilitate students processing those experiences, making meaning of those experiences. The use and the development of a flexible tool to help clinical educators with this work. And when I say this work, I'm talking about facilitating supportive conversations with learners is lacking. And so this certainly inspired Jamie and I to look at, can we do something or help support instructors in some way in these beginning conversations to support students when they know that they've experienced a situation and are experiencing distress. And so that led to our recent publication that Jamie's going to talk about here in a minute, that focuses on using the PEARLS simulation framework that was developed by scholars in medicine, that's underpinned by a trauma-informed approach to guide support.
Great. Thanks so much, Juliana. So much good information there. So I'm going to transition into talking about the tool that we created to help support these conversations. I'm just going to go into a bit of a background regarding the PEARLS framework for those who may not be familiar with it. PEARLS is a framework that we use mainly in simulation education. So it's titled Promoting Excellence in Reflective Learning and Simulation. It was originally published by Adam Chang and Walter Epic back in 2015, and it is one of the most widely used simulation debriefing frameworks out there. The goal of the framework is really around providing structure to these debriefing conversations that we have with learners. And so it has a bit of an opening and it has a bit of a closing, and then there's a middle piece that has different arms to it. So I'm going to speak a little bit to that, but the middle piece is what we kind of call the analysis, and it can have many different branches, such as advocacy inquiry, a learner-centered approach, a plus delta. There can be focus facilitation, there can be directive feedback and teaching, which sometimes is needed. this PEARLS framework can be used both in short debriefing sessions in simulation as well as in long ones. So when we were looking at wanting to create a tool that could help support clinical educators with these, post-clinical or during clinical conversations with learners after critical incidences, the PEARLS framework seemed to fit really nicely. And prior to our publication, there was only one paper that highlighted using PEARLS in post-clinical conference in undergraduate nursing education. And so we really wanted to lean into that. So we've made some sample PEARLS framework that we will share with you shortly. But I just wanted to extend a caveat that the application of PEARLS in this context is not considered an intervention. Rather, it's offered as one way to be present and interact with learners using an empathetic and compassionate approach, especially after critical incidences. And it's important to know that those on the call who do facilitate simulation-based education, that we're still able to abide by the NACSL standards for being a simulationist and being trained in debriefing. So this framework that we're proposing, that we'll share with you, is really around supportive mechanisms in clinical experiences and does not completely allow for robust transferability to the simulation setting, as they are two different conversations. So I'm just going to dive into a bit of the phases of PEARLS. So the reactions phase. This is really important to highlight, as Juliana alluded to, regarding the emotions that may be solicited during clinical experiences with undergraduate nursing students or learners in any context, or peers or colleagues. And so the point of the reactions phase is really around sitting within soliciting prominent emotions. Now, we know that from Juliana's research that students may not be open to sharing how they're feeling about a certain situation because they are worried about that evaluation component. And so again, that preview and that prefacing that this is not about an evaluatory conversation, but it is really about a personal connection and a check-in. But again, we know that nursing students, and again, related to gender or cultural context, may not want to disclose how they are truly feeling because they don't want to be perceived as weak or do not want to be evaluated. But it's really important that we open up with this question and really sit with any potential discomfort or emotion that comes with it. And that can be really hard for clinical instructors, especially if you're new and not sure how to navigate these emotions. But in all honesty, after a significant critical incident, a major medication error, or patient death, or a really aggressive, violent, patient encounter, students may be so incredibly rattled that you may just sit in the reactions phase for majority of that, supportive learning conversation. And it's important that we recognize the significance of this. I say a lot of times in simulation debriefing that emotion clouds cognition. And so if there is any really important learning outcomes that need to come of this from a patient safety lens, that we create a safe space to disclose our emotions so that we can, if we need to, move towards the content and the learning that may take place later on in the conversation in post-clinical conference or mid-conference. And that, again, going back to Juliana's advice around setting up safe spaces early on and getting to know your students, both if, in the classroom setting and in the clinical context, but creating connection with students is so empowering and allows that safety piece of them feeling more comfortable to open up to you if they are feeling particularly distressed. It is just really important that we recognize that when emotions are high, that learning can be impacted, and also it can contribute to increased patient safety errors. I just had an incident with an employed student nurse this past week who experienced some incivility within the workplace and was feeling really heightened and emotional during the shift. And what came of that is that she had 2 near misses during the rest of the shift with the medication errors, because she was so feeling emotionally flooded around some of the things that were said by colleagues in the moment. And so again, just honing into the importance of discussing emotions and reactions. And if you're seeing those verbal cues in your learners or your students, those physical appearances. Maybe they've got clenched fists, or they're holding back tears, or they're not making eye contact. Be aware of that and lean into that, and maybe that's your point of checking in with them and diving into these conversations. But again, we don't want to force it. Emotions are uncomfortable. We want them to be able to disclose, and we want it to be a voluntary conversation. But leaning into that trauma-informed approach, especially within the reactions phase, is so important. It does remind us to slow down and create safety and hold space for reflect before we dive into a more cognitive reflection. The descriptions phase is really around, in simulation, we like to kind of highlight what the summary of the case is. In the clinical context, we really want to ensure that ourselves as the clinical instructor are aware of what the student or the learner, what the perception of the event was. Maybe we weren't witness to it, we didn't see it, we didn't hear anything that went on. And so we really want to get from their lens what actually occurred. And can you give us a brief description of a series of events? Did your patient, become, have a seizure? And so what did that look like? And what did you do if you weren't there as the clinical instructor? And so just really getting a good handle on the description of events is really important, so that as the clinical instructor, you can help provide supportive strategies in any learning that may occur later on. In regards to the analysis phase, in simulation, we really root it back to looking and reviewing about our learning objectives. But in this case, that is not what the objective is. The analysis phase is really rooted in staying learner-centered. And this is so incredibly important, because we really want to make sure that we are having a student-led discussion. And if they want to just talk about the medical and clinical context, that we lean into that. But if you hear them talking about how emotional they're doing, and then they're kind of or how emotional they're feeling, and then they're really kind of spiraling into how they're not a good nurse and they don't know if they can continue doing this, we need to really pay attention to what is being said and how we can help support. And again, within the learner-centered approach, we offer within our cognitive aid the ability to do a bit of a plus delta. And one of the components to Juliana's work regarding the pushing down and pushing through publication was around promoting self-reflection regarding to positive occurrences and what went well. And so asking that question, you maybe had a traumatic event, this was your first code blue, but let's talk about reflecting on what went well for you in that situation. What are you proud of? And that's such an important piece within this framework, because everybody, we're naturally, we lean into that negative bias within our self-reflection, and nursing students particularly are additionally hard on themselves. And so we really need to promote that positive reflection within the analysis phase. So we'll give you a few examples of suggestive questions and strategies to use within this phase when we get to the next slide. And lastly, the summary phase. So the summary phase, again, in simulation, I usually go around the room and ask people, what's one thing that you take away from this simulation? But this is very different in the clinical context. The summary phase is really around ensuring that our students are supported regarding well-being and how we're going to show up the next day. How, if they had a really impactful critical incident, do they feel safe returning to clinical that day? Do they maybe need to go? Do we as the instructor need to, allow them to process the events, go for an extended lunch, or even go home for the day, ensuring that we are going to follow up, provide resources, what do they need for self-care, and what do we need to do to help support them to return to clinical the next day or the next week? And that is our job, to help support any of those, needs that the student is requiring. And again, if it comes down to medical or clinical context, is there identified, self-identified, or perceived knowledge gaps that then again, as the clinical instructor, maybe you spend the next day reviewing code white policies or code blue policies, and that's maybe something that is a summary or a takeaway from these clinical events. So this is our tool that we created, so using pearls to guide supportive conversations. So it is adaptable. We just want to make that clear that you do not have to go through every single column if it's not going to work for the time that you have and the significance of the event. You will see that we have a few rows here. The row 1 is regarding examples of a trauma-informed principles. Then we have considerations for you as the clinical instructor or the educator to consider when entering into these supportive learning conversations with students. And then the bottom part is all around sample phrases. So we provide you a few different sample phrases that you can choose to use or make your own that suits the situation. And we're going to work towards you adding your own flavor to it. But we just thought it was nice to provide sample phrases regarding each part of working through the Pearls framework. So we have the setting the scene, reactions, descriptions, analysis, and summary columns within this guide, and this is located within our paper. So just to kind of break them down and how they apply to trauma-informed principles and some sample questions. So setting the scene, this is really around, again, that safety and building trust, and that we allow the students to have a choice in the matter. They may be so rattled or flooded based on whatever occurred, that they may not have the capacity to enter into these conversations with you within the clinical environment. And that is their choice. This is not a mandatory conversation, but you are offering to step away and have a conversation with them or their clinical group. So a sample phrase that could be used in this is, I would like to sit down and have a debrief with you. Are you okay to talk about it now? And have them be able to say, yes, now is a good time, or no, I'm not in a good headspace. Can we talk about it after the clinical day or tomorrow? And so allowing for that opportunity for choice. In regards to exploring reactions, again, this may be short depending on how much they're willing to disclose, or you may sit in this phase for the majority of the conversation for as much as the time may allow. And it is really important, again, looking at a trauma-informed approach, that different cultures and different genders may be a bit more reserved or may feel more comfortable disclosing how they're actually feeling. And it's really important for us to not force that, but just to understand the different lens of where students are coming from. Again, we really encourage you to be mindful of your own body language and demeanor and your tone, because this could be a really vulnerable position for a lot of our learners. And within this phase, again, we really encourage a lot of normalizing and validating. So normalizing that, seeing a patient, pass away for the first time is distressing. It absolutely is. And sometimes it doesn't get easier. And so just really validating that this is a very real and raw experience that they're having. And so leaning into that is a really important piece of the reactions phase, and exploring their emotion and really validating those experiences. So some suggestions, sample phrases. You've experienced a distressing situation and everybody responds differently. How are you feeling? And then just sitting back and making sure that we really have active listening during this phase. So we're not responding to text messages. We're not on our computer. We're really staying present with the learner in this moment. Within the description phase, again, this is around collaboration and mutuality, what really occurred. Open-ended questions are helpful to assisting in summarizing the event. We want to ensure this is all around a shared understanding of what actually occurred. Again, sometimes there can be perception mismatches depending on what you as the clinical instructor with years of experience perceive of the situation versus maybe a novice learner. So it's really important that we hear where the student is coming from and what their understanding of the clinical event and what happened. So can you tell me a bit more about how this situation unfolded, or what do you think might have occurred? What's your perspective? And hear if they can actually identify maybe what happened, and maybe there's a significant knowledge gap that they weren't able to relate the patient's confusion and agitation to progressing sepsis, whatever that may look like. And so then that's really helpful for you as the clinical instructor to be like, oh, interesting. Those are not, two separate things. They're likely related. And so then you can lean into that a bit more in the analysis phase. So in the analysis, this is around getting curious, again, open-ended questions, offering a plus delta, what went well, what didn't go well is usually what we do in simulation, but this is really around to gain new insights and self-understanding. So again, staying very learner-centered. If there's one thing that they just really want to talk about repeatedly, then we lean into that as the instructor, because that's what's going to provide the most benefit to them. So some sample phrases. Can you tell me something you're proud of, or you feel like you did well in this situation? Maybe it's something small, that their patient had a seizure and they called for help immediately. It's really important that we applaud and reinforce those positive behaviors, and that they can leave feeling like they still did something well, and they're still going to be a great nurse at the end of the day, and that we're here to support them. But we really want them to identify and self-reflect on that. Because again, they could just want to focus purely on the negative and what was missed and what didn't happen. And we need to really make sure that we're supporting them to look at the other side of things. So some other questions: how might you approach a similar situation in the future? And then finally, the summary, or closing the loop. Again, Juliana really reinforced the importance of peer support. So maybe encouraging them to all take a coffee break together, knowing that they're peers, for them to kind of be even more vulnerable with. If they're aware of what occurred in the clinical environment, they might need that time with their peers. But also for you, how can I support you when returning to your next shift, is a really important question that we need to be asking as clinical instructors, to hear what they would like for us and how we can stand in with those supports, whether it be significant enough that they require counseling services through the university, or a different assignment for the next day, maybe a day off, or whatever that might look like, to help support the learners to be able to return. So some example questions of how to lean into this. And again, the cultural and historical and gender trauma-informed principles are really important in this, because every student may respond differently to what they are wanting and needing from the clinical instructor at that time. So before we go into our reflective learning activity, we just wanted to kind of pause and see if there was any questions. We do have something in the Q&A, I'm seeing. Oh, there it is, sorry. If a learner is not good in describing their emotions, what tool can we use to probably explore how they feel, as it is subjective? It may mean to different people. Just wondering how we can. Yes, so yeah, Juliana, you and I can both respond. I would say that one of the tool that we published could be helpful in trying to get them to maybe name their emotions. But if they're not able to, we can even throw out, are you feeling overwhelmed today? We could give them sample suggestions to try to name it. And if they can't, an important one thing I do is I say, I'm noticing in your body language that you're, looking at the ground, you're playing with your fingers. Is anything going on for you? You don't seem like yourself. And just kind of naming, we say, like, call out the elephant in the room. And a lot of times if learners are in significant distress, I won't say a lot of the time, but they do tend to show non-verbally that something is not going on with them. Maybe they're not asking a lot of questions, they're not their bubbly self, or they're really shut down, or they're seeing a bit on edge. And I think calling that out is really important for us. It gives us weight that we are acknowledging that there's something going on, and we're not just disregarding it and we're like, oh, they're really off today, I'm just going to ignore that behavior. But we're really leaning into exploring if there's something is going on, because maybe they're just waiting for somebody to ask them if they're doing okay. And so I think it's important that we recognize the nonverbal communication that a lot of our learners can present themselves, especially if you have had them for a few weeks and can recognize a bit of an external behavior change. Juliana, do you have anything to add to that?
It's just to recognize that some might not share their emotion, even if they are feeling an emotion, and that's okay. So offering choice and option in terms of when and who they want to share that with is okay. Noting you look upset or you're quiet, do you want to talk about it? And if they don't, that's okay, that's their choice. But there are resources if you want to explore emotion further, and I'm available as well. So I think it is about, again, the trauma-informed principle of voice choice. Respecting when they're ready to disclose and share that they will or not. Yeah, I'm not 100% sure I'm familiar with a tool that will allow you to capture that, but I think the principles are lovely to keep forefront when we're thinking about how do I navigate that. So thank you for asking the question. It's a good question.
Yeah, and there's another great comment in the chat with a resource, a paper, Perceptions and Experiences of Psychological Trauma in Nursing and Psychiatric Nursing Students. So that's a great resource. So thank you, Catherine, for popping that in the chat for us. Oh, moral injury. I'm just reading in the Q&A. It simply means you're just psychological safety, genuine. Yeah. Thank you so much. Yeah, moral injury, I'm seeing a lot more literature around that right now. And it's a great term that I hadn't heard of a few years ago. So it's brilliant that you're doing some work around this. Yeah, great. Thank you. Just for a great way. What are your next projects? Oh, Juliana, you probably have something on the go.
We're actually working on understanding the perspective of the clinical educator at this point. So there's been a number of our projects have focused on student perceptions and experiences. What we haven't captured is the clinical educator's perspective on how do you recognize, how do you know that a student might need support, and what are you doing at this point to offer them support, and is it working? And so that is in progress at this point in time. Thank you for asking the question. And then it just leads to another project and some more and more. So it's really evolving work, exciting work.
I'm just there's some more in the chat. I wonder if you have any recommendations about clinical incident reporting. Yeah, I will say since I work within a health authority and not within academia anymore, it is going to look different, I think, site to site. So within the hospital environment, we absolutely do encourage critical incident stress debriefing and critical incident reporting. But I think within every health authority and wherever you are located across Canada, that's going to look different. For my local hospital, if there is a critical incident that is deemed critical by a group of staff members, we do report. That can be a report to WorkSafe BC for psychological distress and impact, and then it also can trigger a what we call a cold debriefing or a formal critical incident stress debriefing a couple days after the clinical event. And so that can look different depending on where you're at, but we do have a provincial reporting system as well. That being said, if it is just a subjective, personally related event to a nursing student, perhaps, they might require follow-up through the university as well as the hospital environment, and that, again, can look different.
Just before you go on to the next step, I just want to point out, Catherine had shared her work around bringing an emotion wheel the simulation and or clinical. So in terms of a tool to explore emotion, her work, which she's added in the chat, might be a great resource on how to navigate that. So thank you for sharing that piece.
Yeah.
Jamie, you can go ahead and do the next step.
Okay, sure. Code learning, that's great. Yeah. I'm just gonna try and there are some other questions. Do you want us to, there's one more. Specific measurements and indicators or markers utilized to identify stress and anxiety. Do you see that in the chat?
Yeah, none that come to mind right now.
No.
Let me think on that.
Okay. Great, so we are just going to see if for those who are able to stay about doing a practice session. So we wanted to give an activity that I popped into the chat, and we will put up our cognitive aids. So what we're going to be asking of you, if you have capacity to, because this is a webinar and we're not able to do small breakout groups or come off for conversation and role play, we're going to ask that you do some self-directed reflective learning. So use the tool that we'll put up on the screen and work through the framework independently or in a group with, if you're in a room, and write out what you might say to the learner if you were the instructor with this student. And afterwards, we'll return for a large group discussion. We would like to hear, after you apply the tool to a clinical conversation with the learner, how this might land with you, if you think this is a benefit to your practice, any challenges that you experience, any sort of different way that you may ask about things. So I will put the tool up on the screen for us to use. And we'll just give it a couple of minutes, probably no more than 5 minutes, to see if this is something that you could lean into and see using in your clinical practice if you are working with students in the clinical environment. The case is of a third-year nursing student who was walking a patient to the bathroom and stepped away, and the patient unfortunately fell and did sustain a head injury. And the student was visibly shaken, crying, and informs the instructor that they're feeling significantly impacted. So they're repeatedly asking questions about what they could have done different and appeared quite physically distressed. So you pull them away to have a conversation. So I'd encourage you to just write out or think about what you might say in this moment. We'll just do one more minute. So thinking about some discussion for those who are able. I just wanted to pose a question or two. So I think we would just like to hear from you if you were able to work through the activity. How did you find the tool that if it worked for you about thinking about approaching conversations like this? Is this something that you can see being a benefit to your clinical practice? You can just pop your comments in the chat. That'd probably be helpful. And if you were to encounter this situation in real life, if anything, what would you do differently? Extremely beneficial. Great. Thanks, Maggie. Yeah, it provides a guide for conversations. That's what we were looking for. I know when I was starting out teaching years ago, something like this would have been really helpful, especially with, I had many students that had distressing situations, and I did what most people do when they're uncomfortable and don't know, is we avoid it. We avoid leaning into these conversations, and we avoid conflict. We avoid emotions because they can be really tricky. Thanks, Louise. Yeah. I would just say that with as I usually recommend for any simulation educators who are learning how to pre-brief, adding your own flavor and your own style of questioning and your own linguistics to it is really important. You don't have to follow the scripts word for word. We don't want it to come across as scripted. We want it to come across as authentic and genuine. So however that may look for you, but it is just a nice tool to kind of review prior to going into clinical. Yeah, thanks, Elizabeth. Yeah. Over time, you may develop your own style. Yeah, exactly. To have in your back. Exactly. You got it.
Jamie,
Yeah.
you might have noted is it may not be linear. I think important to note that it may not be that you go step 1, step 2, step 3, that sometimes you may actually just sit in the emotions reactions phase.
For sure.
And that's okay. It might feel like I need to get through each component, but it might not be relevant because it's really about just really getting to the crux of the emotion. And so you need to just sit in emotions, and that itself is supportive, not having to go through the full entire tool. So just an FYI, I think to note.
Yeah, great. We are often stressed and emotional as well. That's so true, Kristen. Kristen actually wrote a beautiful paper as well on post-clinical conferencing and resiliency. But I am so glad you made that point, because as clinical instructors, we may be emotionally charged by the situation as well. So I think ensuring that we are in a good headspace to actually have these conversations and be able to support other people with emotions when we ourselves are dealing with emotions is a whole other lens. And maybe this isn't even the time to lean into these supportive conversations if we're not feeling like we are mentally and emotionally and cognitively able to. And so doing a bit of that self-reflective pulse check is a very real situation, especially if it was distressing or there's multiple things going on, or if you're feeling overwhelmed and not able to provide that emotional support. We don't want to do more damage or put our emotions on the student, for example. So it's a really great point you made. Excellent. Well, thank you. Just in the essence of time, we will just highlight this is the paper if anybody's looking for a reference, and all of these slides will be sent out after the webinar, as well as an evaluation. So we really encourage you to fill that out. We would love to hear from you. For those who may be leaving, I will just pop it into the chat. This will all come from Cousin as well as a follow-up. If you were able to give us some feedback, that would be excellent. We would love to hear from you. And any other questions before we round out today? There's our information if anybody wants to get a hold of us. Diffusing model, yes, yeah, thanks, Lee. Yeah. Yes, what do you need to take care of yourself exactly, Lee? Yeah, that's a great question to ask in the summary phase. So thank you for saying that. Yeah. What's the worst part for you? Reactions. Love that. And how can we make our improvements? Okay, well, thank you. Aw, Marty, thank you. That's great. Yeah, please share widely. We'd love for people to use it, especially for any new clinical instructors that are entering into the workforce these days. So thanks.